The next session, we now have Ana Cabañas as our moderator.
Hello, as they said, my name is Ana Cabanes. I'm Senior Advisor at Global Focus on Cancer, and I'll be moderating this session on personalized or precision medicine and the road to make it standard of care. We have four fantastic speakers today, and that will provide first a basic introduction on precision medicine in breast cancer. Then we'll share two examples of initiatives led by civil society in LMICs, one in Brazil, one in Indonesia. And finally, we'll also hear about public-private partnerships. We have two reactors in the room that will help us, for the discussion. And we also have Dr. Julie Graylow also to complement the two reactors. So we have a tight agenda, so without further ado, I will introduce you to the first speaker. Dany Bell is a strategic advisor for treatment medicines and genomics at Macmillan Cancer Support in the U.S. Dany is an oncology nurse. Prior to joining Macmillan in 2014, she worked at the National Health Services of the U.K. for 30 years, 31 actually, working clinically in surgical oncology and palliative care, and a variety of roles in senior management. So let's hear Dany.
Thank you, Anna, for that introduction. I'm pleased to be here today to talk to you about precision medicine. So what's precision medicine? Precision medicine is essentially the tailoring of medical treatment to the individual and the individual characteristics of each patient and their disease or their response to treatment. It's a form of medicine or treatment that uses information about a person's genes or proteins to prevent, diagnose, or treat disease. In cancer, precision medicine uses specific information about a person's tumour to help make a diagnosis, then plan their treatment, or to find out how well treatment is working, or to give a more accurate prognosis. Precision medicine can also be called personalised medicine. It is in contrast to a one-size-fits-all approach, in which disease treatment and prevention strategies are developed for the average person, with less consideration for the differences between individuals. In cancer, precision medicine is different from today's more common treatments and common treatment protocols that tend to use surgery, chemotherapy, or radiotherapy based on the tumour location. Without data to differentiate patients and identify who might have a specific genetic mutation or predisposition to a disease, patients are treated similarly in those standard treatment forms, whereas with genomic testing, specific and more precise information about the person and their cancer can guide a more precise treatment plan. The idea of precision medicine isn't new, but recent advances in science and technology have helped speed up the pace of this area of research. Scientists now understand that cancer cells can have many different changes in genes, proteins, or other substances that make the cells grow and spread. They have also demonstrated that even two people with the same type of cancer may not have the same changes in their cancer. So even though researchers are making progress every day, the precision medicine approach to cancer is not yet part of routine care for most patients. The basis for personalised medicine and understanding the role of our DNA plays in our health can help us transform how we think about healthcare. Whole genome sequencing provided a huge step forward in the diagnostic information available in looking at an individual's entire DNA, rather than looking at specific genes or groups of genes, and can help deliver what is called the 4 Ps: prediction and prevention of disease, more precise diagnosis, personalised and targeted interventions, a more participatory role for patients. By combining and analysing information about a person's genome with other clinical and diagnostic information, patterns can be identified that can help determine individual risk of developing disease, detect illnesses earlier, and determine the most effective interventions to help improve health, be they medicines, lifestyle choices, or even simple changes in diet. This can help move away from simply managing an illness and instead focusing on promoting health, the ability for clinicians to discuss with their patients information about individual genomic characteristics, lifestyle and environmental factors, and interpret personal data from wearable technology will drive a new type of conversation, and it requires new knowledge amongst professionals, patients and the public to have the confidence in using information available to them in treatment decisions and lifestyle choices. In order to have more precise information about a person and their cancer, it is necessary to undertake biomarker testing. This could be sequencing the whole genome or testing for a range of specific biomarkers. So what is a biomarker testing in cancer treatment? Biomarker testing is a way to look for genes, proteins, and other substances that can provide information about the cancer. Each person's cancer has a unique pattern of biomarkers. Some biomarkers affect how certain cancer treatments work. Tumor markers have traditionally been proteins or other substances that are made at higher amounts by cancer cells than normal cells and are found in the blood, urine, stool, and the tumor itself, or other tissues or bodily fluids. Increasingly, however, genomic markers such as tumor gene mutations, patterns of tumor gene expression, which is a process by which a gene gets turned on in a cell to make RNA and proteins. Gene expression may be measured by looking at RNA or the protein made from the RNA and what the protein does in a cell. There are also other kinds of biomarkers that can help doctors diagnose and monitor cancer during and after treatment. Biomarker testing for cancer treatment may also be called tumor genetic testing, genomic testing or genomic profiling, molecular testing or molecular profiling, somatic testing, tumor subtyping. A biomarker test may be called a companion diagnostic test if it is paired with a specific treatment. Biomarker testing is different from genetic testing that is used to find out if someone has an inherited mutation that make them more likely to get cancer. Inherited mutations are those you're born with and they are passed on by your parents. Most biomarker tests used to select cancer treatment look for genetic markers, but some look for proteins and other kinds of markers. Some tests check for a single biomarker, others check for many biomarkers at the same time and may be called multi-gene tests or panel tests. One example is the Oncotype DX test, which looks at the activity of 21 different genes to predict whether chemotherapy is likely to work for somebody with breast cancer. Some tests are for a certain type of cancer like melanoma. Other tests look for biomarkers that are found in many cancer types. The results of a biomarker test could show that a cancer has a certain biomarker that is targeted by a known therapy. The matching therapy may be available as an FDA-approved treatment or an off-label treatment, or through participation in a clinical trial. In many cases, biomarker testing may find changes in a cancer that won't help with the treatment decisions. For example, genetic changes that are thought to be harmless or whose effects are not known, and these are alluded to as variant of unknown significance. They're not used to make treatment decisions. When biomarker tests find genetic changes that people may have been born with, inherited changes, that increase the risk of cancer and other diseases, these genetic changes are also called germline mutations, and they may have implications for wider family members who will subsequently have to go on and have genetic testing. The benefits of personalised medicine can be classified into three main categories. Prediction and prevention of disease with obvious benefits to the healthcare system and improved patient management of disease and health. Delivery of better treatments for patients with reduced adverse events and improved survival, with improved targeted drug treatment and efficacy. And also the right treatment for the right person at the right time in the right dose is generally the aim. However, it's not without its challenges. The challenges include access to and quality of patient data and ensuring appropriate consent for data use. Large sample of data to identify discriminatory factors between groups of individuals to evaluate therapeutic interventions is required. And so this can lead to data protection and data breach issues. Also, the costs of drugs can be challenging in some healthcare systems. Although there have been huge advances in whole genome sequencing, which can now be done quickly and cheaply, digitalization of patient records often lags behind and is variable in different healthcare systems, and as is standards for data gathering. And often you need the infrastructure for inputting data is variable in different healthcare systems. In some cases, there's fragmented databases, which causes a challenge. However, the benefits of personalised medicine are definitely proven in oncology, as well as in some other diseases, where biomarkers have been identified and specific treatments developed. Precision medicine for breast cancer is an approach to diagnosis, treatment, and prevention that takes into account the genes the individual was born with, so their genetic makeup, and the genes of other markers present in their cancer and their cancer cells. With this approach, a patient's blood or tumour tissue is collected for analysis, and this information is then used to predict or diagnose cancer and guide treatment decisions. Personalisation starts with screening and earlier detection through mammography, and also those with family history of breast cancer who are at higher risk of developing breast cancer themselves, having access to screening. So, for example, women who carry the BRCA1 or BRCA2 gene mutation would need to have screening as they're likely to have inherited risk. Breast cancer is diagnosed by breast biopsy or an excision and then subsequently staged. Estrogen receptor, progesterone receptor, and human epidermal growth factor receptor biomarker testing is performed to establish hormone receptor status, which provides both prognostic and predictive value in the diagnosis. Women with early stage invasive breast cancer and known to be estrogen receptor positive or progesterone receptor positive or human epidermal growth receptor positive status may then benefit from prognostic biomarker panels that can provide information to guide decisions about adjuvant therapy after surgery. So this is called gene expression signature testing. OncoDX, EndoPredict, and Prosigna are 3 representative multi-gene tests that are commercially available to do this. In drug gene testing, as genes influence the way our body processes medications, including those used to treat breast cancer, information from a genetic test of a patient's cells will be used to determine which medications and dosages are most appropriate for the individual patient. The field of drug-gene interactions is called pharmacogenomics. In advanced cancer, circulating tumour cells may be present, and they're frequently detected in metastatic disease, often by doing a liquid biopsy. In terms of family history, up to 10% of all breast cancers are due to specific pathogenic variants or mutations in single genes passed down in family members. BRCA1 and BRCA2 are the best characterised and most prevalent breast cancer susceptibility genes, but there are others such as ATM, PALB2, TP53, and a host of others that are associated with an increased susceptibility of getting breast cancer in your lifetime if you have these genetic mutations. In terms of other testing, liquid biopsy and circulating tumour DNA, often referred to as ctDNA analysis, is emerging in breast cancer care, particularly in areas of research. It's not currently recommended as part of standard care at the moment in guidelines, and also circulating tumour cell counts are not recommended as standard of care by ASCO, particularly in early disease, much more useful at the moment in metastatic disease. A recent meta-analysis suggested that circulating tumour cells testing has clinical validity as a prognostic marker and may provide useful information to clinicians and patients. However, the results may not provide actionable information that can impact clinical outcome. Precision medicine and targeted therapies have a long history in the treatment of breast cancer and continue to show great promise for the future. The goal of precision medicine for breast cancer, as previously highlighted, is to tailor treatment to a patient's specific genetic makeup and the genetic changes in the cancer cells. Breast tumours that are estrogen receptor positive could be prevented or delayed by using anti-estrogen drugs or like tamoxifen and aromatase inhibitors like anastrozole. And these were the first targeted drugs in breast cancer, and in fact, the first targeted drugs probably in any cancer. Then other targeted drugs known as monoclonal antibodies, such as Herceptin, are treatments when there are large amounts of the protein HER2 in the tumour. There are now several agents. Herceptin was the first monoclonal antibody, but as you can see, there are other drugs now in that group of drugs. And then conjugated monoclonal antibodies work. They're a combination of monoclonal antibodies and a chemotherapy drug called DM1. And so essentially the monoclonal antibody binds the cancer cells and then delivers the DM1 to them. So that's why they're called slightly different name, conjugated monoclonal antibody, and not just a monoclonal antibody. And then you've got cancer growth blockers, such as palbociclib and lapatinib is a small molecule drug that acts within the cell to block downstream growth signaling, which is caused by receptor activation. So you can see moving from chemotherapy to estrogen drugs to targeted drugs has been the change in cancer treatment for breast cancer. In advanced breast cancer, the use of hormone therapy in combination with a new kind of agent, which is the cancer growth blockers, palbociclib, might be used as the cancer growth blocker targets the proteins, and particular proteins that are cycling dependent, so CDK4 and CDK6 on cancer cells. And these proteins stimulate the overgrowth of cancer cells. And so cancer growth blockers do exactly what they say, and they kind of block these proteins and block that growth. Be interesting to look back at the evolution of cancer treatment, breast cancer treatment in the UK, just to see the evolution of those different types of treatment. So originally, breast cancer was treated as a local disease where the primary treatment was radical surgery. And then over time, radical surgery evolved into breast conserving surgery, followed by radiotherapy to control local disease. However, advancements in breast cancer since the 1970s have shown an increase in the different types of targeted drugs that we use. And we also know that women with incurable breast cancer live much longer because of the evolution of the different kinds of drug treatments. So prior to the 1970s, surgery and radiation were the staple treatment options. But subsequent to the 1970s, chemotherapy was introduced in young women with early breast cancer and demonstrated improvements in their survival. In 1980s, we saw the impact of the anti-estrogen drugs and the use of tamoxifen and subsequent other drugs in that drug group. And then we saw in the 90s the more awareness of hereditary risks of cancer. So whilst we were aware of BRCA1, the BRCA2 gene was also discovered. And so there was more insight into that hereditary risk, lifetime risk of getting breast cancer. So in 1998, Herceptin was FDA approved for metastatic breast cancer. And there are certainly other drugs in that group as well now that treat metastatic breast cancer. And in the 2000s really was the kind of approval and much bigger use of monoclonal antibodies. And then obviously in 2013, we saw the Angelina Jolie effect in terms of her announcing that she, as a Hollywood actress, was a BRCA1 carrier and she'd had a prophylactic bilateral mastectomy. And it really raised the awareness really of inherited breast cancer. And so therefore the therapeutic options for breast cancer patients have dramatically increased in the 21st century. And there are still increasing efforts towards the development of more efficient and effective screening, diagnosis and treatment options for women with breast cancer. So in summary, personalised medicine is the future of cancer treatment, but to make it a reality in the near future and to be able to offer improved treatments to all patients, we need to understand that the patient has an active role, and this active role is crucial. Shared decision making is really important, and the information and the language that we have for patients around personalised medicine to be able to help them participate in the decision about their treatment is really important. Thank you very much.
Thank you, Dany. This was great. It is a concept that is not very easy to understand, but this was a very good summary. You just said that personalized medicine is the future of cancer medicine, and that to make it accessible to all, the patient's active role is key. In your experience, could you give me an example of how patient involvement has played a role in increasing access to personalized treatments?
I think the key answer to that is around campaigning. So I think we know without women with breast cancer and equally people with other diseases trying to get access to treatments, their campaigning plays a huge part in influencing the accessibility of those drugs, because I think their lived experience and their voices are pivotal and really important. It's not always just about the cost of the drug and all the other things. It's about the significant impact that certain drugs have on somebody's quality of life and their long-term experience of treatment for their cancer.
Thank you. Thank you very much. Thanks for your presentation, for your time, and we'll pick up some of these concepts again in the Q&A after all the presentations. Thank you, Dany.
Our next speaker is Dr. Maira Caleffi, who's the Chief of Comprehensive Breast Cancer Center at Hospital Moinhos de Vento in Porto Alegre, Brazil. Dr. Caleffi is a breast surgeon providing care to patients who is also involved in population-based research for breast cancer early detection and access and treatment for LMICs. On July 2006, she founded FEMAMA, which is a federation of NGOs in Brazil, in the city of Sao Paulo, and with the mission or the objective to influence the formulation of the national public health policy and ensure universality, integrality, and equity in breast health attention in the context of a whole health and full rights for Brazilian women. Maira again could not travel to Manila, but we recorded the session, and here we have. Thanks.
Thank you, Anna, for the introduction. It's my honor to speak to you, my colleagues and friends from Southeast Asia. Today, we're going to speak about some topics on precision medicine, but more of all is how we are trying to introduce precision medicine to our current cancer care. We're talking about humanizing healthcare, precision medicine, personalized healthcare, the importance of the voice of the patients, awareness, advocacy, and patients' education. Today, for me, one of the most important concepts about precision medicine is humanizing healthcare. This is the key to rebuild sustainable healthcare systems and improving personalized cancer care at the bench of the patients. The concept of humanizing healthcare is not yet clear, but it's all about working hard in hand with patients and stakeholders to create a more personalized approach. We're talking about patients, we're talking about people. And this concept has been discussed at IEPO for the last year or so, and you can find a position paper in many languages, translated in many languages, in our website. We have there 5 categories validated by the international patient community. First, putting people at the heart of healthcare. Second, humanizing health literacy. Some people don't understand what doctors and professionals are talking about. Next, humanizing digital healthcare to build capacity by harnessing the power of patients' data. Patients' data has to be also in the hands of patients. Fourth, organizing healthcare to focus on prevention and cure with a new 50-50 model. This means 50% of the investment put in prevention, education, and 50% on diagnosis and treatment. The last but not the least, we need to prioritizing diversity and be more introduce more every type of people. Precision medicine relies on the ability to treat patients based on the biomarker status on the tumor. This is, as a conventional approach, we used to have one-size-fits-all approach according to the stage, according to maybe the age. Nowadays, precision medicine approach can really, through biomarkers testing, to tell exactly the type of the tumor everyone has. So we can fit exactly the treatment approach for that particular patient. So we select treatments most likely to benefit the patient by knowing the different biomarkers that tumor tell us or the family history tell us. There are many variables that a doctor as myself, when we're putting the treatment together to deliver and discuss with the patient, we need to take in account. There is a problem about having personalized healthcare available. And this is just for you to know that in Latin America, we did a very important study here with a group of people trying to rank in Latin America how personalized healthcare is delivered at the moment. And we can see that we have a very big lack of technologies. We have a very discrepant health information among the 10 countries that I mentioned there. And Brazil, my country, we're not doing so well about policies and having, for example, government thinking how it's going to bring personalized healthcare to our people. We are pushing very hard, and I'm going to give you some examples in a few moments. How to make the voice of patients impact and put pressure on the government to build public policies. So this is my contribution to this very fantastic panel that we're putting together here, because I think we need to unite forces. We have an umbrella organization that called FEMAMA in Brazil since 2006. So we now are getting the 18 years old closely, but we need to coordinate the actions in the whole country through our network to make it an impact in changing policies. So we have been thinking very much about the patient journey approach. So since the first symptom until treatment and after treatment, we have been proposing bills, legislations for the whole country to speak in one language. That means timing and quality is very, very important in cancer care. So many of you know about the 60-day law that puts timing between the diagnosis in pathology to treatment. Just after that, we started the 30-day law that is already in place. And more so, now we are fighting to implement the notification, the mandatory notification of every single diagnosis of cancer in the country. You see, this is what FEMAMA has been done through like the highlights. We've been doing a lot, but I'm just thinking that for you to know that we are not only incorporation of new treatments, trastuzumab here, and was an example in 2017 and was available 10 years before in other countries, or even for patients in Brazil that had insurance and money. But we managed to put together many stakeholders, and 2017 we managed to have that available, and it still is. I'm going to give you some examples. For example, how do we do it? The 30 days law that is putting a time between first consultation to the diagnosis is like being very important in Brazil, because we find that the primary care system is not integrated with the rest of the system. So the patients stay there. The women, talking about breast cancer, that is my area, they know that they have a lump, they know that they have a problem in the mammogram, but take time, too much time for them to get into the pathology report. So we do technical visits. We did 500 letters to submit it to the congressmen and senators. We did public hearings to make those parliamentarians to know what we're talking about. Don't be fooled and thinking that they know what they are doing. Sometimes they have to be taught what to do. We have to tell them what is going on. So we did a lot of mobilization, even in the streets, in a lobby day. In one day, this vice president was in a public hearing here, and I went there and I made him sign, and he did. So this kind of thing, you have to have the 10-second speech, 30-second speech, and you have to understand that advocacy is something very, very, very quick that you have to do one ask at a time. So at the moment, we are bringing precision medicine, how we can offer to the patient. And we are fighting for the availability of the genetic testing for women, mostly younger women or women that have family history. This is not available to 90% of our population at the moment. And this is really precision medicine. I'm going to leave all these slides. I'm rushing because Anna gave me a few minutes to talk about my life to you. So we have 3 questions that we are saving more lives. This is the Pink October, and I don't understand why it's not appearing here next. But we are taking the Pink October 2022 campaign to speak about the risk. The first question we are thinking about early diagnosis, but the second and the third we're talking about science. Do you know the recent scientific advances against breast cancer? Do you know the treatments for each type of cancer? So this kind of buzz that we're going to do in the whole country, talking about science, talking about types of tumor, is a way to introduce personalized medicine, personalized health care in the minds of the patients, to ask for that, and for the legislators and the policymakers. Look, I'm finishing here, but I want to leave my message that I'm running for the U.S.A board this year, 2022 to 2024. And all the members of the U.S.A can vote. Put my name there, please, on October 11 online. So my mission is to make patients' voices stronger globally and more present in the health political agenda. Thank you very much. And I hope I do badly about timing, Anna.
Thank you, Maira. Yes, you did a little bit, use more time, but was fantastic presentation. It really, I think it's very, very inspiring. So I have a question for you. You work under FEMAMA in Brazil, which is a partnership or an umbrella organization of many other organizations. How can you translate all the learnings and best practices of all the work you've done into the global space? There is such a need to be able to do initiatives like you do in Brazil, in other places of the world. So tell us a little bit, how can you go from being just national or in Brazil to really expand that impact globally?
We need, Anna, to find common agenda. We need to collaborate more, because I'm sure in Southeast Asia, and now that we have these opportunities virtually, we can interact more often. And I hope you can do more of this, Anna, because you've been fantastic when you've been putting us together to think. But I think collaboration is the word to say here. And when we started to work together, now we are 75 NGOs in Brazil working together. We come together every year and we're going to fight for 3 priorities. We have a whole agenda, but we have to put our minds in few priorities and work very intensely until we get it.
Fantastic. Well, thank you so much, Maira, for presenting today. I really hope that your ideas can be really translated globally and really help people, not just in Brazil or Southeast Asia, but all over the world. Thank you.
Excellent presentation by Maira, a true advocate at heart. I mean, there is no question about that. She has also, I really like this vision that this global perspective of collaboration and participation around the globe. Next, we'll hear from Ms. Ceisy Nita Wuntu. She is a teaching staff at Faculty of Languages and Arts at Manado State University, North Sulawesi. She was diagnosed with breast cancer in 2018 and joined the patient organization Indonesian Cancer Information and Support Center, also known as CISC, in the same year. She was treated with trastuzumab, and she then created the breast cancer HER2 positive community group at CISC. She will be speaking about their efforts to include treatment anti-HER2 in the public health reimbursement system. She is going to speak from Indonesia, but she's going to speak live. Thank you. So, Ceisy, the floor is yours.
Okay. Thank you very much, dear moderator. And ladies and gentlemen, good afternoon. Well, I'm Ceisy Nita Wuntu from Indonesia. I am now in Manado, the northern part of Sulawesi. I am really close to you in Philippines and affiliated in Cancer Information Support Center Association Indonesia. I am a 4.5-year survivor breast cancer of the subtype HER2 positive. It has been also introduced, and it is easily understood of why it is I who present this topic. So, well, I'm so grateful and honored to be among of you represented all elements connected to cancer in Southeast Asia. I'm really glad to be here for sharing CISC experiences, ideas, and advocacy. This is really grateful for us all. So thank you also to ICANSERVE Foundation Inc. and the committee that have invited us to take part in this great symposium. Ladies and gentlemen, while dealing with personalized medicine, I will be talking about patient voices, targeted therapy for breast cancer subtype HER2 positive in Indonesia, and it will be presented from the perspective of Cancer Information Support Center Association, CISC Indonesia. Hence, this presentation will firstly talk in brief about the organization. So our organization is Indonesian Cancer Information Support Center Association with the vision Indonesia Care for Cancer. And it was established in 2003, and 70% of its members are cancer survivors from all types of cancer. So the activities of this association as a support group and also providing information and education publicly and particularly to the patients. And we are having also program lay patient navigation at the hospital. And we also empower members by training those who can train others, especially to educate others, and providing information as training of trainer of speaker. And we have also yoga and dance classes, etc. So we also provide patient lodging for those who belong to National Social Security Agency of Health. And also we are doing advocacy to help patients access the expensive medicine. So from the data of Globocan, in 2020, the amount of new cases, breast cancer cases, is 16.6% from the new cases, grand total of cancer, and it is almost 400,000. Breast cancer impacts patients physically and psychologically. This is the main issue that seemingly have been understood by us all. But the specific things that are noted here are 90% of breast cancer patients in Indonesia are in productive age. So the range is 25 up to 55 years, and many of them still have children living at home, and they have to work and have family responsibility and etc. More likely to experience specific comorbidities, including fatigue. The psychological issue associated with breast cancer, including anxiety, loneliness, depression, anger, guilt, fear of recurrence, and body image changes. The greater life stage challenges felt by younger women with breast cancer in adapting to the unexpectedness of breast cancer diagnosis, including possible losses in their career, family life, and fertility. HER2 positive early breast cancer patients in Indonesia are not guaranteed and so neglected in the National Social Security Agency of Health. For that reason, the mortality in Indonesia, in this case dealing with breast cancer, is higher than in neighboring countries. Breast cancer is the leading cause of cancer death. About 21.4% of Indonesian women. There are around 22,000 deaths, so it is about 17 per 100 women among those breast cancer patients. This is higher than other developing countries, as Thailand, only 10.5, and also Vietnam, only also 10.5%. And breast cancer brings impact to patients, their family, and increasingly becomes burden to the society. There are more and more breast cancer women losing years of healthy life. As we all know that diagnosing and treating HER2 positive breast cancer early before it has spread may provide the best chance of cure. When breast cancer is diagnosed and treated early, it is potentially curable by preventing the disease from returning or reaching an advanced, incurable stage. About 1 in 5 breast cancer women diagnosed with HER2 positive. Those women will have faster disease progression and poorer chances of survival. Around 70% of breast cancer women in Indonesia are actually have the chance of cure because they are in early stage. Actually, stage 1, stage 2, and stage 3. However, 15% of those women early breast cancer patients die within 1 year. 1 year mortality rate in other countries are range from 0 to 9%, where more than 70% of breast cancer women in those countries still alive in 5 years. HER2 positive early breast cancer is a governmental priority in other countries, including developing countries, with the availability of highly effective HER2 targeted therapy in their reimbursement coverage. The issues of breast cancer, HER2 positive, that are not guaranteed by the government through National Social Security Agency of Health seems to affect the effectiveness of treatment. This is shown by the data here, in which the mortality rate of early breast cancer is the same as the mortality rate of metastatic breast cancer. Mortality rate of early breast cancer patients in Indonesia is higher than other countries, and similar with mortality rate in metastatic breast cancer patients. As a result, that many of them are not treated optimally. Concerning the issue of early breast cancer in Indonesia, CISC is there to do the advocacy and assisting the patient and the survivor of breast cancer HER2 positive. Currently, there are about 394,000 members, 94 members, of HER2 positive community in WhatsApp group that is made about 4 years ago. More importantly, CISC is now educating and improving literacy of patients and caregiver to understand the treatment journey. Example, by involving media engagement, webinar, seminar, forum group discussion, Facebook fan page, and WhatsApp group. CISC is also enabling patients to partner with doctor in making treatment decision. Example, collaborating with partners to develop joint decision aid. We are also navigating patient and also are developing patient navigation program at hospital. And we are doing policy advocacy on assessing to her to positive care. And the last one is about building capacity on evidence-based advocacy by doing research collaboration with university. It is now being done with Gajah Mada University. And about advocacy efforts, it is based on the objective of inclusion of trastuzumab for early breast cancer in the reimbursement system in national social sorry. In National Social Security Agency of Health Indonesia through action of social media engagement, discussion through webinars with medical oncologists, policy expert, academicians that are covered by the media. And also, we write letters to the policymaker, to the Ministry of Health, and also to the National Social Security Agency of Health Indonesia.
You want to drink some water?
Sorry.
You want to take a minute?
Yeah, sorry.
That's okay. I'm sorry.
Yeah,
Also, some of the slides are not moving, and I think that they're really interesting. So if you could push it to the double click.
Okay, can I continue this?
Yes. Yeah.
Okay. So the social media engagement, discussions through webinars with medical oncologists, policy experts, academicians that are covered by the media. And also we write letters to the policymaker as to Minister of Health and also to the National Social Security Agency of Health in Indonesia. And reach out to the parliament together with other patient organizations. And then we join the breast cancer patient journey in forum group discussion. We are also doing, we are also doing ongoing research in collaboration with Gajah Mada University to identify obstacles to get access to cancer care for breast cancer HER2 positive patient. And the last one is the program of doing the engagement with stakeholders to help realizing the advocacy. We have here, okay, so I think this is the final slide. So we have here pictures of HER2 positive community activities. Picture number 1 is the the launching HER2 positive community, and picture number 2 the same. It is the same event when the community of HER2 positive is launched. And then picture number 3, this is taken when CISC launched HER2 positive book. And then picture number 4, and this is one of HER2 positive webinar photo. So to conclude, it is to say that all of us should improve early detection, and also breast cancer patient can get quality diagnosis and treatment according to their cancer subtype, especially early stage breast cancer subtype HER2 positive. Thank you.
I'll ask you a question. Your campaign uses a combination of tactics similar to what Maira was talking before. You have a slide that we were not able to see, but you explain all the tactics that you use. It was community mobilization, meeting with politicians, social media activation, webinars with doctors and researchers. I think that, this is it's a great project and very similar, not quite the same as Maira's, but have you had a chance to share these with other groups in the region, and so they can replicate, or at least so you can discuss what are the best things that work in every setting?
Yeah, we usually do a webinar. So frequently we usually do webinar, and we in the webinar we usually invite doctors to share the information, or to educate all people, including the patient and also the families are involved in the webinar. I think it is really effective so far.
Excellent. Thank you very much. Please do not leave, or I think, can she stay? Yeah, please stay for after a little bit of a discussion. So I'm going to introduce our fourth and last speaker, Dr. Diana Edralin. Diana is the general manager of the pharmaceutical division of Roche in Philippines. She has played a variety of leadership roles with Roche, and she has consistently championed for co-creating, integrating healthcare solutions with different stakeholders. Diana is also the current president of the Pharmaceutical and Healthcare Association of the Philippines, PHAP, and as the first Filipina president, she advocates for improving access to quality healthcare and innovation for Filipino patients, bringing multiple stakeholders together for the advancement of a patient-centered healthcare ecosystem. Diana will present in co-creation of personalized healthcare and will describe concrete examples of from Indonesia, Malaysia, and Vietnam. Diana, the floor is yours.
Thank you, Anna, and welcome to Manila, and welcome to all of you who are dialed in online and on-site. Good afternoon. Thank you for this opportunity to partner with the Southeast Asian Breast Cancer Summit organizers and ICANSERVE Foundation to discuss this important topic on making personalized healthcare a standard in breast cancer care. So for the next few minutes, I would like to share with you and hopefully inspire you on how we can make personalized healthcare a reality for all of us today through co-creation and partnerships. And I think both Ceisy and Maira already started inspiring us. Over to the next slide. These are my disclosures. Our healthcare landscape has transformed drastically and dramatically over the years, finding ourselves in a situation, for sure, even your cell phones right now on your laptop, where advanced technology and the magnitude of information has been exponentially increased. At the same time, we also find ourselves becoming more engaged and more involved in our own health, And consequently, this has also given rise to find a more personalized way of managing healthcare for each individual, helping us understand better that no two persons are the same. Now, over to the next slide. The next one again, and to the next. Thank you. And this is what personalized care, as already discussed earlier by the few speakers, it focuses on healthcare plans and decisions around a person rather than the condition. It also considers what makes us all unique, such as our age, our gender, our genetic makeup, our lifestyle, along with our personal needs, and highlight on the personal needs. Over to the next slide. And what does a personalized healthcare plan mean for all of us in real life? It means having a tailored care to your unique needs or our unique needs, and also even for the persons that we care for. And I think that's very important. This is not just about us, but also for the family and the communities that we actually care for. And in terms of early detection and diagnosis, that means having to receive an earlier, more accurate diagnosis that leads to a more targeted treatment. In cancer, we all know that the earlier we detect it, the better chance we have for a successful treatment. And when cancer care unfortunately is delayed or not accessible, there is a lower chance of survival and greater problems actually associated with treatment and higher costs of care. So in terms of prevention and prediction, personalized healthcare also allows for the identification of potential conditions that we may be at risk of and the lifestyle changes that can actually prevent them. At the same time, PHC, or personalized healthcare, leverages technology and our health data to better manage, understand, and monitor our condition. When that data is readily available, for example, through electronic medical records, which is still a journey for a lot of low-middle income countries. So these EMRs, when they are made available in the hospitals or perhaps the national database, this can also mean that you will be able to quickly identify what are the resources that are available for you and what are the healthcare solutions that can work better for you. Over to the next slide. Thank you. Next slide. So now you might be wondering, this is something that I really need and for the people that I care for, but is it just science fiction? Because this looks like far from the reality that's happening today. But you know what? I have great news. I think our colleagues from LATAM and Indonesia have already shared with you, this is already happening. Our clinicians have been working through the years to have a tailored approach to people's individual needs throughout history of medicine. But never before has it been possible to predict how each of our bodies will respond to specific interventions or identify which of us is at risk of developing a specific illness. So back in September 2016, the National Health Service of England, which is a publicly funded healthcare system, published their vision of what personalized medicine is all about, entitled Improving Outcomes Through Personalized Medicine, Working at the Cutting Edge of Science to Improve Patients' Lives. It featured on how genomic or molecular diagnosis was made available for patients, and that means having the opportunity to better understand the genetic base and using that information to help select the most effective treatment, which also improves the chances greatly of survival in some types of cancers such as skin, leukemia, colon, brain, and of course, breast cancer. Next slide, please. So today, PHC is a reality for most of our breast cancer patients. As you can see, there are countries in LATAM and Indonesia advocating for biomarker testing. And now it's a part of standard of care. And also at the same time, personalized healthcare and even genomic testing now even offers a promise of breast cancer types wherein there is an unknown primary site or whether it's too advanced or difficult to treat. So we have actually gone this one-size-fits-all standard with the biomarker testing, as mentioned, being a standard that also allows for targeted treatment instead of just having your standard chemotherapy alone. And in the future, what we are aiming for is to have the right treatment for the right person at the right time. Next slide, please. So you might be wondering, how can actually we make that as a reality in terms of collaboration, as was mentioned by Ceisy earlier, and the advocacy that comes with it. So to make that vision of the right treatment for the right person at the right time becomes a reality, it takes an entire community, a movement that brings different stakeholders together to deliver the healthcare solutions that are specifically designed for the individual's needs. And each stakeholder and decision maker takes full ownership in driving the advancement in PHC that they are actually accountable for. But I also want to highlight that at the center of all this is you. As patients, caregivers, and advocates, you are the key drivers of change in making sure that your individual preferences and needs are taken into account in your healthcare plan. Next slide, please. So I want to share also, next slide, please, thank you. I want to share some of the best practices that we have had here in Southeast Asia. Again, for most of these countries, even in the Philippines, we're low middle income countries, but that did not deter us or prevent us from actually advancing healthcare, specifically around personalized healthcare. So you will see in the example of Vietnam, they were able to establish and made available the comprehensive genomic profiling, but this time it's only for the private patients in the private hospitals. What they're also working at the moment is to ensure two things. Number one, it's made available for the public sector or the government hospitals in that it gets reimbursed. The second is to ensure, remember, when there are treatment options, whether it's biomarker testing driven or it's from the comprehensive genomic profiling testing, it means that the drugs or the treatment should also be made available. Unfortunately, in Vietnam, the same situation in the Philippines, sometimes it takes about approximately 2 to 3 years to get an innovative treatment approved and actually funded. Now over to Indonesia, so it was already shared earlier, there have been progress around the biomarker testing as a standard for breast cancer, but fortunately they're also working for the same thing around lung cancer. So they have also made sure that CGP is available and accessible, but what's also different here is that they are trying to build a personalized healthcare coalition and actually drive a roadmap so they can actually monitor their progress and the milestones that lead to it. And fortunately, I think Anna and I have been also discussing this around the partnerships with the medical societies and academic societies. So they're also working on doing a Master of Precision Medicine study program to actually upskill also their healthcare professionals. And with Malaysia, so this, I think Malaysia is a bit more advanced too, because now they're focused on establishing a data-driven decision-making and policy shaping that also has to drive, again, the specific improvements around personalized healthcare. They also want to, with the policy shaping, they want to create an environment so that PHC becomes fully supported from end to end. At the same time, I think the partnership also with the healthcare professionals and advocates have led them to actually use clinical support decision tools so that when the results of the biomarker tests or the CGP are out, it's also easy for the healthcare professionals to interpret it, because that becomes a huge barrier in terms of implementing and actually taking on the recommendations from the CGP. And next, and of course, sorry, back to that slide. So all of this are actually driven by their advocacy towards getting this real world data through different platforms. And I think this is one of the things that we also need in terms of personalized healthcare, actually seeing what the outcomes are. It's not just the implementation, but are we actually achieving the patient outcomes that we have hoped for? Next slide, please. So the Philippines, again, for most of you, if in case you still don't know, we are definitely one of the low middle income countries. And we are one of the markets that still is, unfortunately, self-pay. But fortunately, on the flip side, we do have the universal healthcare already in place and also the National Integrated Cancer Control Act. So through the years, there have been significant efforts towards shifting to equitable access, improved service delivery, health financing, and also reducing system inefficiencies. So back in 2019, on Valentine's Day, February 14, the National Integrated Cancer Control Act of the Philippines was actually signed into law. Now, we are focused, both the public and the private sector are moved towards its implementation and the adequate funding that entails for it, again, to make sure it becomes a reality and not just a very nice law in paper. And we have also moved into forging partnerships towards the advancement of personalized healthcare, specifically on making sure that there is a national registry. Unfortunately for cancer, it's still work in progress. So the medical societies, the NICA Council, and even the private sector in the pharmaceutical industry is also supporting this. Second is around partnership with the medical and academic societies. One of the things that we'd also like to do, or at least would like to see a reality, is how our clinical practice guidelines are actually reflecting biomarkers testing, comprehensive genomic profiling, and the latest innovations that are actually already made available. And hopefully it doesn't take, again, 3 to 4 years for us to have that made available for all the Filipino patients. Right now, our Philippine National Formulary, I think there's an opportunity for us to really update that. And finally, you can see that there has also been significant progress towards education and access on the comprehensive genomic profiling. As of today, I think it has been made available since 4 years ago. Different companies are making it available locally. There have been expansions, and there have been more than 1,000 Filipinos who have benefited from CGP. But that is a significantly low number compared to the number of patients diagnosed for cancer each year. I think yesterday it was shared that based on the GloboCan 2020 data, there are at least 27,000 Filipinos have been diagnosed back in 2020. So 1,000, I think we're going to get there, but it takes a community to do that. Over to the next slide. So this is actually very small, but listening to this, I think what I would like for us to have is what is actionable after listening to this session. What can you do to make sure that personalized healthcare, as mentioned earlier, is not a science fiction, but a reality? So the lobbying piece has already been shared. I think there's an opportunity for us, whether you are a breast cancer patient, a cancer patient, or caring for someone who has the illness. Personalized healthcare goes beyond cancer, but we have to take accountability. We need to have a demand for it and lobby for it. I appreciate the example earlier from Maira, and I think we need to make a stand and come together to make sure that, again, specifically around not just a law, but the funding, adequate funding gets actually implemented. The second that I'd like to highlight is around data privacy and laws. So the databases for these genomic profiling learns from the different genetic makeup of the people participating in the program. So we also have to make sure that the databases are easily accessible. But for me, specifically for the Philippines perhaps, what we can start is with electronic medical records to begin with. Maybe databases are advanced, but the EMRs will make it easy for us and for a national cancer registry to actually be in place. And then finally, I think what's not listed here, but I was now being inspired by the different countries, partnerships and collaborations across Southeast Asia. I think we can, together with the different advocacy groups in different countries from Vietnam, Malaysia, Indonesia, and Philippines, how can we inspire our government to actually come together? How can we have a multi-country approach rather than an individual approach? Will our voices be louder if we do that? You know, is this something that you'd like to do in the next couple of days and start discussing? So with that, I'd like to go on to the last slide saying, you know, it's personalized healthcare is something that is meant for all of us. It's something that becomes a reality, but it will not come to life if we don't come together. The public sector, the private sector, at the center of it are the patients. And we can achieve this by working together to change the healthcare system. Again, having the right treatment for the right person at the right time. Thank you.
I would like to invite Dr. Julie Grelo to stage as well, and Dr. Hardy Luna as the reactor. You can, yeah, is it here? And Dr. Arthur Liu, he's online. He's online. Hello? No. Yes? It works? Yes. Okay. Okay, well, thank you very much. Diana, I'm going to start with you because you didn't get a question. You talked a little bit about the role of healthcare providers. You know, we talk a lot about advocacy groups and government, and you mentioned healthcare providers. In the Philippines, nurses and the Nurses Association is very strong. How could you leverage their influence to really push for these more personalized medicine?
Thank you for that very interesting question I actually shared with Dr. Luna earlier. So I think the first thing that comes into mind is, again, a multidisciplinary approach. I think MDT is something that we can further institutionalize and really leverage on, not only for breast cancer, but also for the different types of cancers. Now, with the role of nurses, and especially to your point, right now we have an exodus of our nurses going to the other countries, and more of these specialized nurses. I think most of them are, not wanting to specialize anymore, or maybe wanting to go to different countries because they have the voice, but I think we don't have the system or consistent system to make sure that they become partners in that treatment. Because all of the infusions that are happening, of course, it comes from the doctor's orders, but at the same time, the personalization of that approach. How do you cater to the preferences of your patients, having a convenient way? And I also want to highlight, let's say, even today, there are treatments around intravenous infusion, but also there are also subcutaneous formulations. But how are the nurses getting the information and giving also back to our healthcare professionals as to how you can further modify that? Because I think the nurse's role is also very important in terms of adherence. So that's what good looks like for me, and how we can further promote that, and also how we can have a specific program, let's say for the Philippine government, to ensure that our oncology nurses are definitely part of that, and how we can also make them stay, so that they can continuously evolve or transform the healthcare specifically for breast cancer patients.
Great, thank you very much. Dr. Grelo, could you please, and we were supposed to hear the general concept of precision medicine in the first presentation, but we were unable. And when we talk about precision medicine, our head goes immediately to targeted therapies, but there is more than targeted therapies. Could you just very quickly as you can, summarize, the pieces like a diagnosis or for prevention, or when, in which stages do you use precision medicine in breast cancer?
I think we should be using precision medicine from prevention to diagnosis, through treatment, and through survivorship care, because precision medicine, personalized medicine really is different at each stage. We talk about it more with respect to treatment, but in the prevention piece, we need to know the family history, the genetics, the risk factors, and that can tell us when we need to do screenings and things too. So So I think it goes across all stages of the whole continuum of breast cancer.
Thank you. Thank you. And I would like to hear from our two reactors. I'll give the floor to Dr. Luna, who's here with us.
Hi, good evening. Delighted to be here. So basically, our talk for this afternoon focused on the patient. So we have, again, it was Dr. Grillo mentioned a while ago, it's the patient's journey from prevention to survivorship, and gone are the days that we put them in a box. So for personalized medicine, there are efforts to improve on survivorship, mortality, morbidity by applying medicines. On top of that, we also have precision medicine in other specialties or fields as well, be it surgery, precision medicine in pathology, as well as precision in radiology. So there's improvement in science, but we in our country, in the Philippines, this precision medicine, the next generation sequencing is very costly still. Most of our conversations with our patients in a government hospital, they would want 110,000 tests to be converted, next generation sequencing tests to be converted to treatment already. So it's really a hard call for physicians, and it's also a great deal for patients because you're communicating the importance of genomic or personalized testing, but you also want to hear their voice in committing to treatment already at this early stage and time. On top of that, access. I know there are few access for next generation sequencing, personalized medicine, and the education about it. There are a lot of hesitations still because, number one, of the cost. So I honor the comment a while ago about collaborations and helping each other support this, be it insurance, be it policies in healthcare, etc. So there's a way or better path to improve science in that aspect. In addition, for the physicians, there's a lot of things we need to learn about precision medicine, the precision testing as well. The platform, its interpretations, the results, it differs from one platform to the other. So we need to improve on this as well. So that's for the part of treatment. Then going to the earlier phase, prevention. I am so amazed with the 30-day law mentioned by Dr. Maira a while ago. I hope we have something like that in the Philippines because it matters. Early detection, early cure, it saves lives. However, in the Philippines, social media, misinformation, and a lot of second opinion from non-specialists really do cost time. This delay in time causing more fear, cripples the patients, and instead of empowering them, it really causes delays. And how can we bridge more patients to survivorship? How can we say no to stage 4 if they themselves commit or they themselves consent to these alternative options? We're not saying that these are bad options, but again, we need to communicate, educate, clinically evidence-based medicines from those that are hearsay. So again, the awareness, the support, and the access. Some of the patients will tell you, I have no funds for these medicines, chemotherapy, even it's cheaper nowadays compared to years before, like 2 decades ago. Still, they cannot afford it. So I really honor the partnerships, the collaboration, the advocacy of everyone in this hall, be it government officials, patient advocates, cancer support groups, even survivorships, because all together with the physicians, scientists, we all have the same goal to bring better medicine, to create better practices, and to have better survival outcomes for our patients.
Thank you. Thank you very much.
Thank you.
Dr. Arthur Lowe, we would like to hear your reaction.
It's good day, everyone. I hope I'm coming in clear.
Yes.
Yeah. Okay. Thank you. Thank you for having me here. So just I'm a medical oncologist and I practice south of the Philippines. So first of all, I'd like to congratulate the organizers and of course the speakers. It was truly heartwarming for me as a clinician to listen to the true advocates, the vision of the speakers that we had. That was something very heartwarming to listen to. First of all, I'd like to really just comment on how personalized medicine, precision medicine has changed over time. We've probably seen how we have improved in terms of how cancer care has evolved over the past, I'd say, 1 or 2 decades ago. Prior to this, everyone, just get chemotherapy. That was all we had. We didn't know better at that time. Over time, we've learned, especially in breast cancer, to know that, not all breast cancers are treated alike. And I think this is the initial concept of personalized medicine. We've learned, that, a certain subtype of breast cancer responds better to this type of treatment versus this type of breast cancer may get a better outcome with another type of targeted treatment. A good example of which would really be HER2 treatment for HER2 positive breast cancer. I think if you recall historically, I'm sure in the Philippines and in other parts of the world, everyone will get the same treatment as all types of breast cancer. But we've learned how to do HER2 testing, like here in where I practice, south of the Philippines, not in Metro Manila. We do have good HER2 testing. We've learned how to do HER2 testing as routinely as we can. And that, I think, has really changed lives. And I think that is where a lot of research should come in. We should get to try to understand more how to personalize treatment for breast cancer. We've also learned a lot as well about biomarker testing early breast cancer. Which subtype of patients will benefit from getting chemotherapy and which subset of patients who will not. I think this has been brought up. Oncotype DX, tests like these, it helps us choose patients who to get treatment. We've also looked at around how we have been having more genetic testing, germline mutation testing, wherein we try to identify high-risk individuals. But I guess ultimately these are things that we know that has improved over our how we treat our breast cancer patient. But ultimately, I think in the Southeast Asian community, in middle low income countries, I think the question again, as Dr. Luna mentioned earlier, is this technology available? Do we make this personalized medicine available for only the select few? Or do we want to bring this to all the involved patients in the community? I think that is something that we all have to reflect. And I'm sure a lot of things have been done, meetings, advocacies, etc. So truly inspiring. But I guess there's still a lot more things to do on this matter. We cannot make something available only to a select few. It has to be something that has to be for everyone. And again, the next question is it available? The next question is, if we get drugs, like in the metastatic setting, like in lung cancer, we've learned so much about personalizing treatment in lung cancer. Are the drugs available? Are the drugs accessible for these patients? That's another big question. You send a test for a patient and tests come out, say, like, you need drug XYZ. Is drug XYZ something I can bring into the country? Is it something that the patient can afford? And I guess that's also something that we need to at least improve. I've always looked at, going back to the treatment, I've always looked at how research should support how local scientists. And I'm sure, I think in other countries, we now have local panels, local testing in university hospitals. And I guess for low middle income countries, that's something that we might need to look into, having these tests locally available rather than sending them out. Takes 3-4 weeks to have results in, and making the low and middle income countries stand on their own. And I think that's something that over time might be something more sustainable for everyone. And I think hopefully will answer accessibility and availability of all these new technology for our patients. Thank you.
Thank you very much. Very good reflections to end the session. The first speaker that we didn't hear, she ended her presentation saying two things, collaborate and campaign. And I'll leave it like that. Thank you very much for your participation, and we'll close the session now.